Okay, so good morning and welcome everybody. I want to introduce myself first. My name is Dr. Mohan Krishnan. I'm the Director of Children's Services at Hope Network's Behavioral Health Services, and I'm here today to talk to you about autism. I want to first of all thank you all for coming out. I know it's early on a Saturday morning, and I'm sure that, like me, you'd rather be out walking your dogs or having a late breakfast or something like that. But I'm really excited that you've taken the time this morning to come learn. And I hope that we can have a good time learning about autism this morning. I know there are a lot of really exciting topics through the rest of the morning and the afternoon. A couple of quick reminders. It is a really cramped room and it's also quite warm, so take those two things into consideration. If you need to step out anytime, I will not be offended for a drink of water or something like that. So please just bear with us in terms of the cramped spaces. Hopefully get to know your neighbor a little bit. This lecture will go for the full 60 minutes, and I do have stickers for your CE certificates at the end. I think that's the only thing that I need to tell you. There are bathrooms around the corner out in the main hall whenever you need them, and there'll be time for questions hopefully at the end as well. But if you're not understanding something along the way, it's fine to interrupt as well, please. So I want to start by asking for a quick show of hands here, because I've actually never been to this conference before. How many people here are preschool teachers? Okay, so that's a lot of people. Is anyone a school teacher K through 12? Okay, so a couple. Is anyone an in-school therapist, a social worker, occupational therapist, speech and language pathologist? Okay. Is anyone an in-school, any other kind of in-school service, a parapro? Anything like that. Is anyone a clinician or from the healthcare environment? Okay. Any parents of kids with special needs? A couple of those. Okay. Anyone I missed?
Home daycare providers.
Sorry?
Home daycare providers.
Oh, okay. Excellent. Welcome. All right. Well, I think then hopefully I've got the right information for this audience. Welcome. Please make yourself comfortable. There are a few seats up here. So I'm going to emphasize today talking about screening in the early childhood environment, and particularly talking about a basic background of what autism is, for those of you who may be more or less familiar with it, how it's diagnosed and treated, understanding signs and symptoms that suggest an increased likelihood of autism, particularly in kids who are in the preschool age range. And then understanding some formal tools that can be used for screening purposes and learning mechanisms for clinical follow-up especially. I'm sure that you all know more about academic follow-up than I do. I'll mention that briefly as well, but you're probably already more of an expert on that than I am. So those are things I'd like to try to accomplish today. Briefly about me, I actually used to be an engineer and I studied at the University of Michigan. I did my psychology training at the University of Florida and then the University of Chicago's Medical Center. I fellowed here at Mary Fribet downtown, and I've been with Hope Network ever since. I am currently responsible for a variety of children's services.
Thank you so much.
And those include an outpatient autism program, focusing especially on early interventions, but also on lifespan services. And then I do also coordinate residential services for kids with developmental issues. So that's what I do, that's my day job. The Center for Autism, briefly about Hope Network. We were created in the 60s. We used to be the rehabilitation arm of Pine Rest. We've served children with neurodevelopmental issues, autism as well as kids with global intellectual disability or other concerns like FAS. We've been serving them since about 2004 in Grand Rapids in both outpatient and residential capacities. But in 2010, we built the Center for Autism to really emphasize the needs of this underserved population because kids with autism remain, at that time in particular, had relatively little access to clinical services. That continues to be a major issue. And so we wanted to really focus on something that would serve this population. Our emphasis clinically is on early diagnosis and comprehensive treatment planning, and we place a special emphasis on early intensive behavioral interventions. This is a service provided by an applied behavior analyst. So if you've heard of the phrase ABA in the context of autism, that's this, and we'll talk about this briefly, what that is. We also provide a variety of ancillary clinical services additional speech and occupational therapy on occasion, more speech than OT as a booster for services being provided in the school, but particularly also psychotherapy for things like helping families help kids to develop and maintain friendships. And then finally, we provide informal social supports. We have a program called Puzzle Partners, which is a really exciting program for teens and young adults that emphasizes social integration in the community, adapting activities to make them more accessible to people with autism. So this includes things like, I went geocaching with some of our boys this summer downtown. We've done Art Prize with adaptations to make it a more successful experience for kids who have trouble in big crowds. We do a variety of game nights and things like that as well. And then finally, we do educational programming. Once a month, we provide professional education here in Grand Rapids. It's the first Friday at noon. It's called Grand Rounds. Then we also are starting just this month Family Rounds, which is education programming directed more at parents. And that is that happens once a month on a Wednesday night, starting on the 23rd. Yes?
So in order to participate in anything that you just described, would you have to qualify, or somebody has to have autism?
So that's a good question. In terms of our clinical services, they're generally insurance-billed clinical services, and we provide diagnoses as the front end of that. But the diagnosis is going to guide service availability. So for instance, ABA is available to kids with autism increasingly, but it's not available for other kinds of diagnoses. Other things like the social supports. Puzzle Partners is actually much more informal. It doesn't require a formal clinical diagnosis. It's not a healthcare service. And so it's much more flexible. Basically, we look at kids in terms of, currently we're serving kids and young adults who are able to have conversations and who don't have major issues like aggression. Kids who are basically able to function in a group kind of setting. We do some screening to make sure they're appropriate, and we can work with parents to determine that. But that's much more of a come when you can sort of thing. Typically, sessions at Puzzle Partners cost $15, and we have some scholarships available for that too, so that's really accessible. And then finally, the educational programming is, of course, free and open to the public.
Yeah. Do you just serve Kent County or any area?
So currently, our clinic is only here in Grand Rapids. We serve a large catchment area. We have kids come routinely from 2 to 4 hours away for diagnoses, but we're not providing on-site treatment outside of Grand Rapids at this time. We're working on that. I think that's something that definitely needs to happen more. When you look at things like ABA, really high-quality in-clinic ABA is available in Michigan, in the Detroit suburbs, in Kalamazoo, and in Grand Rapids. And that's it. And even Lansing doesn't have access to this kind of care, and certainly northern Michigan, and that's something that's we talk about on a daily basis, how to address that need.
Well, can I ask, what age are children typically diagnosed with autism?
I'm going to get to that.
Okay.
So let me continue, please. Really briefly, I want to mention that, continuing on that, I want to mention that you have a crucial role as educators. Studies, this is a kind of dated study, it's about 10 years old now, suggest that the vast majority of kids who are diagnosed with autism or identified with autism are diagnosed through support of the schools. And in 2003, the study found that only 3% of kids received an autism diagnosis with no school involvement. The other 97% came to clinical attention through you. That may be a combination of school and clinic, so it may be a situation where an early educator said, there's something not right here, and sent them back to their pediatrician. It may be by school alone, and there continue to be a lot of kids who receive academic ASD qualification services, but who don't receive any clinical services. Part of that is because of insurance coverage, and that changed last year and is still in the process of changing. But it's certainly something that we can't do without you, and I want to really emphasize that. So you're crucial to the screening process. And what makes you particularly crucial also is that a lot of you spend a lot of time observing the play and interaction of young kids. And so you're going to be really uniquely able to do that as a professional and as an outsider, not as a parent, to identify kids whose development is unusual. As opposed to a pediatrician who might have a 10-15 minute contact once every 3 to 6 months with that child. So children with autism can also be frequently mainstreamed into general education. That's increasingly happening, and some of the clinical services we provide are really designed to increase the likelihood of that. And so that's something that we obviously have to collaborate on because we want kids to be learning in school. So we really cannot do this unless we work together. And teachers are really crucial. Educators of all kinds are really crucial in making this happen. So I want to spend some time, I don't want to go into this in too much detail, but I want to spend some time talking about a perspective difference that will be important to understand between how we do things in a healthcare clinic and how we do things in a school. We do approach this from somewhat different angles. So there are different terms used to describe things, and some of these terms are used in an overlapping fashion, but some of these differences are important to understand on the ground floor because they do inform the way we do things in a clinical setting, getting back to your question, and how they may be the same or different than how you do things in a school. So first of all, if I talk about academic service qualifications, you probably are all much more experts on this topic than I am. But children may qualify, as you know, for special services in school under one or more mechanisms. But in particular, IDEA and the 504 plan kinds of mechanisms. So for kids who have IDEA services, generally speaking, you have an IEP meeting, and that's initiated in one of multiple situations. You're based on parent concern, based on educator concern, or based on certain kinds of critical incidents that tell you that a child is objectively not achieving what you expect them to, if I understand correctly. And so at that point, when you do that process, you evaluate children for the purpose of determining if they're eligible for services, right? And that's really the core outcome of that first part of the IEP process. And they may be eligible under one or more criteria, and as educators, you may decide as a team what criteria best describe the child. You may provide a blend of services from multiple criteria. And so the plan is customized, although to some extent the services are also going to be driven by the classification the child receives. And the child may be eligible for a criteria that may not match how the family thinks of the child, right? So you may have a child whose family thinks of them as having autism, but they're very high functioning, and you really only see eligibility under an LD criteria or a speech criteria. You might, in contrast, have a family who thinks their child is perfectly normal, but is eligible for fairly substantial services because their development is different than what you would expect. And then a child may also be ineligible for accommodations or modifications, even if they have a clinical diagnosis that a doctor would give them, right? I mean, there are lots of examples of people with autism, for instance, who are very, very high functioning and don't need any kind of help. So if Temple Grandin were in your classroom, she may not at this point need any services, right? So there are also people who may have a diagnosable condition, but they don't need services because they're learning just fine. Or they may need much more subtle services. And autism is a particularly important area where this kind of thing happens because some people with autism may need really substantial modifications to their education, and some people might just need a little bit of help around the edges, essentially. So the purpose of this process is, what I would argue, is not necessarily to treat or cure a disorder, but to adapt the educational process to maximize the outcome. Meaning your point is to make sure that these kids are learning effectively, building up the skills that they'll need to succeed in subsequent education, and then also in the real world. But there's a lot of overlap between what I might call treating a disorder and what you might call maximizing education. So this is the 340.1715, the Autism Spectrum classification for Michigan. And it goes through criteria, and some of these criteria have to do with basically map, essentially. Very hard to read, I'm sorry, and there's no screen. It's a little harder yet. You can find these online pretty readily, and I'm sure that you probably already have a copy. But basically some of these criteria map onto the psychiatric DSM4 language for diagnosing autism. But then there are also some criteria that have to do with how you go about doing the evaluation. So for instance, it requires certain kinds of professionals in the academic setting. It requires the input of a psychologist or psychiatrist. It requires the input of a social worker. It requires the input of a speech and language pathologist. And then there has to be evidence of disturbance in a number of areas. The rate or sequence of cognitive, affective, psychomotor, language or speech development, disturbance in the capacity to relate appropriately to peers, and a number of other things. And I'm going to describe these in more detail. These get to the definition of autism, so I've got a slide where it's a little bit more legible in a moment here. But the point is that these eligibility criteria basically define a set of conditions in which the school credibly finds that a child fits into a category in which you can make modifications or accommodations to education that are likely to succeed and are likely to be necessary. And importantly, success is less likely if these accommodations and modifications are not put in place. Is that pretty reasonable? Okay. Again, I'm not a teacher, and so I want to emphasize that that's the way I understand it. Clinical diagnosis has a lot of overlap, but there are some important differences. The predication of clinical diagnosis is essentially a philosophy that when people come to the doctor and complain about something, we believe there's something wrong, and our job is to figure out what that is. And the technical term for that is differential diagnosis as opposed to diagnosis, meaning among multiple possibilities that explain the complaint of the patient, I'm looking for the one that's the best match for their problems. That may be autism or maybe something else in this case. But what's important about this is, generally speaking, when you go to a doctor with a complaint, you don't go home without a diagnosis. That process, the way that process is supposed to work, is you are supposed to come out of that process with some kind of diagnosis that addresses how you're going to address that problem. Much more rarely, there's no diagnosis at all and it's an educational issue. The child's normally developing and there's nothing wrong with them essentially. But usually people who come to the clinic, it's more a matter of, is this autism versus is it a speech delay or an intellectual delay? Is it an anxiety disorder that happens in childhood? Is it something else? So it's more going to be a differential between these multiple options. And the goal is to find the best explanation. And the purpose of diagnosis is really to guide treatment planning. Whether that be medication or further diagnostics like brain imaging or EEGs or something like that, genetic testing. Whether it be behavioral therapies like in-clinic services like early intensive behavioral intervention. And also to determine what the prognosis is, meaning what the parents should expect about the child in this case. At this point, are we seeing evidence that this is a child who's likely to have a very high functioning trajectory? Do we see evidence that this is a child who's going to continue to struggle on an ongoing basis? Do we see evidence that's inconclusive, depending on how they respond to treatment, for instance? And so really the purpose is to guide treatment planning and help the family do something about the problem that they come to us with. But unlike IEP planning, some big aspects of the picture may be treated on a case-by-case basis. So we might treat emotional symptoms under an autism diagnosis because they're emotional symptoms that really have to do with the autism. But we would treat them much the way we would treat emotional symptoms in kids who don't have autism. Like we would treat anxiety in a high-functioning child with autism much like anxiety in a high-functioning child without autism. So there is some empirical components to this. Very similarly, a lot of medications, hardly any medications are approved by the FDA for autism. Most of them are approved for other disorders where there's symptom overlap with autism. And so, for instance, there are depression and anxiety medications that are approved for depression and anxiety, and they do work in autism. There are some exceptions to that, but a lot of the medical science of treating autism with medications is a work in process, essentially. And I'm a psychologist, and I don't prescribe medications, but I do make recommendations on that and coordinate them with physicians. So the perspective difference is that although there's an overlap of terminology, there's a distinction between the clinical diagnosis, which is intended to identify a medical diagnosis that is the most consistent match for all the symptoms, and the educational classification, which is meant to essentially identify the educational process that is most likely to educate the child successfully. So there isn't full overlap for that. And it is important to emphasize that there may be children who are eligible for ASD services appropriately, but they actually have a different diagnosable disorder in the eyes of a healthcare or medical professional. They may have a specific genetic syndrome that we consider similar to autism, but not really overlapping with autism. They may have another kind of diagnosis as well. And then vice versa, some children who have clinical autism diagnoses don't qualify for IEP services because they're learning just fine, because although their friendships aren't perfect, they're workable. They're able to socially interact at the level that they need to be able to. So that's where there's incomplete overlap between the clinical, medical kind of approach and the educational approach. So when that system works, this is actually perfectly okay. There doesn't need to be complete overlap between the way a clinic does things and the way a school does things. We all share in the goal of leveraging our tools to help these kids thrive. And each child may need a different set of tools, both from the school and possibly from a clinic. And some children may not need one or the other. Like some children may be able to take a medication and stay in a mainstream classroom. Some children may be able to progress so well in early childhood academic interventions that in-clinic services are unnecessary. And that's fine. However, when the system goes wrong, what's going to happen? Well, one is we may miss children altogether. We may have a diffusion of responsibility, and you may think I'm looking for them, and I may think you're looking for them, and nobody's looking for them. And the child doesn't get identified, and they don't get any of the services from either of us that they need. Another possibility is we could spend our time arguing about who's right and who's wrong. No, this kid doesn't have autism. Yes, this kid does have autism. No, this kid doesn't have autism. And that's a waste of time, right? So if we fail to coordinate our services, it's become significantly less likely that our kids will thrive. There's a chair here, and there are two here. Yeah. Sorry, it's a very cramped room. So that's my motivation for saying we want to try to work together if at all possible. And I keep looking back, I'm sorry, I have a screen here, which doesn't show me the right slides for some reason. This is a bit of an eye chart also. I don't know if it's legible on the handouts or not. This is the DSM4 criteria for autism. I want to walk you through it. I don't want to walk you through every piece of it, but I want to give you kind of an overview of how it works. This is actually changing, as many of you may know. We go through a revision process of clinical diagnoses and standards. That happens about once every 6 to 10 years. And the criteria has essentially been locked down over the past couple months. And at this point, we're just kind of in the rollout process for the new criteria. It's a very complicated system because the DSM, the Diagnostic and Statistical Manual, is the generally recognized tool worldwide for diagnosing psychiatric diseases. However, there's another tool, the ICD, the International Classification of Disorders, that's the worldwide recognized tool for classifying all medical disorders. And psychiatric problems are considered medical disorders. Now the problem is that when the DSM changes and the ICD changes, they don't change at the same time. So now we have some new problems that are introduced because the new DSM doesn't match the old ICD. We'll have to work all of that out. Amazingly, this kind of system has been working for quite a while. The DSM-4 is in its 5th major revision this year. The ICD is actually in its 10th major revision. Somehow it works. Sometimes it kind of shocks me that it does, but it does. These are the DSM-4 criteria, essentially the outgoing criteria. And what they talk about is, in essence, 3 major areas of problems for people who have an autism or an autistic disorder diagnosis. And those 3 areas are essentially deficits in functional verbal communication, functional nonverbal communication, and restricted or repetitive or stereotyped behaviors or areas of interest. The first area, functional verbal communication, essentially means that these kids have trouble either learning to talk or, more particularly, learning to talk in a way that it's used for communication. And so there's a range, it's a spectrum. On the severe end, kids may have little or no language output. And in particular, if they do have language output, that language output may be more self-stimulatory, or what we call stimming. It may be there more to sort of amuse the child themselves rather than communicate. So the child may sing songs that they hear on TV, but they won't ask for things with words. That's functional communication. They won't tell you what they need or what they want you to do. If they want you to do something, they may use some other means, like pulling your hand to the refrigerator door. Or they may just cry and let you figure it out. On the nonverbal side, the same kind of concept applies. Body language, gesturing, pointing, eye contact, these are all forms of communication as well. And the point, again, is that these are used to communicate. So kids are looking at you for the purpose of getting your attention. And we'll talk about this idea of joined attention, which is a really important concept in understanding autism. Kids are pointing to get your attention and draw it to something. Like, I want that one, or why don't you go in the kitchen and make me a drink, right? They're waving or nodding. These are all forms of communication using the body. Again, it's a spectrum. On the severe end, these may be completely absent. On the mild end, they just may not be well integrated or modulated, meaning they're used awkwardly. They're used one at a time, whereas if I want you to do something, I might look at you. If I pick on you in the back row, I might say, can you close the door, please? I'll look at you, I'll look at the door, I'll look back at you to see if you looked at the door, I'll point at the door. That's integration of multiple means of functional verbal and nonverbal communication. I'm talking to you, I'm looking at you, I'm pointing, I'm monitoring you. with my vision, right? So that's what I mean by integration. We'll talk a little bit more about that in an upcoming slide. But that's the second piece. So we're not only asking, is it present, but is it well integrated? And then the restricted or repetitive behaviors. In lower functioning kids, it's maybe rocking and flapping and things like that. In higher functioning kids, it's going to be specific areas of interest. And it's going to be an unusual pattern of interest. Experienced clinicians tend to think in exemplars, meaning I think of specific kids who fit these criteria so well that they help me to remember what it is that I'm trying to remember. So if I give you a couple examples from kids I've seen. So an example of an unusual interest area. In a younger kid, we had a kid in Florida who was really interested in radiators and air conditioners and things like that. So we would draw them all the time. If you brought him over to your house and there was one of those outside, he'd be standing over by it looking at it. If you ask him to draw a picture of a person, he'd draw a body with a radiator for a head. Right? So that's an unusual pattern of interest. Even in someone who works as a job, if their job were creating radiators, that'd still be a strange pattern of interest. Right? Another example is when I was in Chicago, I saw a child who was older and he was really interested in football. It sounds pretty normal, right? But this kid's interest in football was that he could draw every NFL helmet for you. And he could give you some statistics and things. If you ask him how you play football or why football is fun, he would look at you kind of blankly and wouldn't be able to answer those kinds of questions. And he didn't play football. He didn't particularly like watching football. And so it's an unusual pattern of interest compared to other little boys who like football. And so you may see one or both of those things. Those restricted area interests can be very consistent over a lifetime. They can also change over time. And then you're looking for some rule-outs. And so for instance, some of these repetitive behaviors happen in many kids who have intellectual delays, MR or DT kinds of kids. And so for instance, lots of those kids rock and flap and spin. And so if you're seeing that in the context of a globally low functioning, then that's less likely to be autism. It has to be disproportionate. Similarly, if you're seeing delays in speech development, but as the kid is learning to talk, they're using all that language functionally, that's much less likely to be autism. It's much more likely to be a language delay. And you want to look out for some specific medical reasons for these kinds of problems. That's actually kind of an area of controversy within the field. There are more and more genetic syndromes that feature things like autism. And if you look at them closely, each one of them, most of them, don't look exactly like traditional autism. But then again, traditional kids with autism don't look one like the other. A high-functioning person who's a friend of mine, the way he said it is, if you met one person with autism, you've met one person with autism. They're all very different one from the other. And so that's actually an area of controversy. Like, are there genetic syndromes that are close to autism, but they're not autism? And for instance, can you have autism secondary to these genetic syndromes? The reason that's a controversy is it affects service eligibility on our side too. ABA, for instance, is only approved for autism and related disorders. And so if it's not an autism spectrum disorder, if it's another genetic condition that causes unusual development in social interactions, it's not eligible for the clinical service. So that's a bone of a contention that we're still figuring out together. The real answer on our side is going to be very similar to the real answer on your side. The question we'd ask is, well, do these other kids, do they benefit from the same therapies? If they do, that's a good argument that these are autism spectrum issues. If they don't, it's a good argument that there's something different about them having the same problems. So I want to briefly mention some other technical terms that are currently used. Asperger's disorder, you've probably heard of, or Asperger's syndrome. And some people say syndrome in particular because this one has a real range. These kids are all, by definition, cognitively normal, with some very rare exceptions. Meaning they have a normal IQ, they met their basic milestones on time. To have the autistic disorder diagnosis, you have to have delayed milestones. These kids have to have on-time milestones. They have to learn to walk and talk on time. But they still have all the same symptoms we just talked about. They have difficulties using language to communicate. It's going to be subtle, especially for older kids. What you're going to find is that that they don't use the subtle aspects of language. They don't understand jokes as well. They don't understand slang or non-literal language or ambiguous language. They don't understand how to use language for things like small talk. Small talk is what they will call a particularly neurotypical activity, and they have conversations amongst themselves about why we do stuff like that. So in the restricted behaviors and patterns, in the nonverbal behaviors, it's very similar. Again, it's going to be poorly modulated eye contact. They're going to be able to typically point and wave and things like that. They may not use these things as often as other people. They may not be able to integrate them together as often. They may have to put a lot of effort into them. A lot of people who are high functioning on the autism spectrum, who have things like Aspergers Disorder, will tell me that they put a lot of work into this. Like, they learn to act, essentially. And when they're trying, they can appear much more like us neurotypicals would expect them socially. But when they're not trying, when they let it go, it's a little bit more obvious. So in other respects, then finally, with the restricted interests, you're going to see special areas of interest mostly. You're going to see less repetitive behaviors, but you may see some of those. And they should still interfere. But in the highest functioning end of this range, a lot of these kids are the ones who go on to do relatively specific areas. These kids are more likely to thrive in an esoteric kind of field. Like, the running joke is that there are lots of college professors who have Asperger's. Because you're allowed to spend all your time being interested in something that 99.9% of the population doesn't really care about, right? That's what it's like to be a college professor. So they do well in that kind of environment. But I do want to emphasize that not everyone with Asperger's has an exceptionally high IQ. It's a range. So they're going to similarly do well with very specific areas. But you'd be surprised. Some of them thrive in areas where you wouldn't expect. More than a few of our Asperger's kids really love theater, because they take it on as a challenge to figure out how to act, like other people expect them to act. And we have, in Michigan, there's a famous basketball player who helped lead Michigan State to a world championship. He actually has high-functioning autism and not Asperger's. But similarly, not exactly a place where you'd expect to find someone on the autism spectrum. They're more and more thriving all over the place, doing all kinds of things. So briefly, there is another specific diagnosis, pervasive developmental disorder, not otherwise specified, or NOS. This is a catch-all for people who are on the autism spectrum, but they don't fit into a specific area. There are a couple of other diagnoses, childhood disintegrative disorder and Rett's disorder, that are in the DSM4 that I'm not going to go into at the moment. And then more and more, there are genetic syndromes associated with autism that are being identified and understood. High-functioning autism is a term you should know. What high-functioning autism means is a little bit inconsistent depending on who is using it. Generally, it's taken by professionals in the autism community to mean children who have the autistic disorder diagnosis, but who over time improve so that their IQ is normal, so that they have most of the cognitive and behavioral skills that their peers have. So kids who can do flexible communication in a complex way using sentences, kids who have a normal IQ, although at a previous time they had a language delay. Sometimes kids who have PDD-NOS are also referred to as high-functioning autism, and that's where the confusion lies. The difference is going to be the kids who have the pervasive developmental disorder, not otherwise specified, are not going to meet all of the clinical criteria as clearly, whereas the high-functioning autism, where it's autistic disorder but there was improvement over time, these kids are still going to meet all the criteria. They're just going to be more subtle than they were at a younger age. And, in fact, these kids who have high-functioning autism, as I'm defining it, meaning autistic disorder with improvement, these kids are actually indistinguishable at school age from Asperger's kids. And that's important to know. Because their IQ is normal, just like the Asperger's kids. What's different about them is that in their clinical history, they had a language delay. And we're still understanding that. Like, is this two different pieces? Is language delay one piece and the rest of the Asperger's autism symptoms another piece? Or is there a reason why some kids have a delay and some kids don't? But if you look at these kids when they're 10 or 11, they're going to be very hard to distinguish clinically. And most professionals would say impossible to distinguish except by their history. And in fact, we wouldn't treat them very differently. So, briefly then, people say autism spectrum. In the current technical terminology, autism spectrum is an informal term. It's synonymous with pervasive developmental disorder. And they're used somewhat interchangeably. They both function as umbrella terms to describe a wider range of kids, all of whom have these same issues, problems with functional, verbal, and nonverbal communication, and either repetitive or restricted behavioral patterns. But it's an umbrella term. Some of them meet these specific criteria like autistic disorder and some don't. And most of the diagnostic disagreement stems from the kids who meet the NOS criteria, the not otherwise specified criteria. Mostly if it's autistic disorder, everyone's going to agree that it's autistic disorder. So the DSM-5 has basically been finalized and it is coming out. It's going to happen. It's going to change things. Some of those things are well understood. Some of those changes, I can't tell you exactly how they're going to work, and we're going to have to wait and see together. But in the new language that psychiatry and psychology are using, autism moves to a new category of neurodevelopmental disorders, which makes sense. It's going to continue to be alongside things like ADHD, but it's not going to continue to be alongside things like, say, separation anxiety. That's more of an emotional disturbance of childhood in a normally developing child. So the new term is autism spectrum disorder, and that's now the formal term in the new DSM, as opposed to pervasive developmental disorder. And this term had been used informally. And actually, that's the only diagnosis. And so Aspergers Disorder is being eliminated from the DSM-5, which is a source of significant controversy, especially because there's a large group of people who identify themselves this way. You are who you are, right? And Asperger, Hans Asperger, and the story of how this term Asperger came to be is no less relevant tomorrow than it is today. But however, technically then, people who qualify for Asperger's and autistic disorder diagnoses would both receive the Autism Spectrum disorder diagnosis. And the new definition requires both social communication deficits and restricted behavioral patterns. And they modified the way that we define behavioral patterns slightly. And these changes were spurred by a lack of clear clinical differentiation between these subtypes. But just like I said, you can't really tell people who have high-functioning autism apart from people with Asperger's after the language delay has ended. And so it's not really clear that they need separate diagnoses, although this is still a work in progress. So this is an eye chart again. The DSM-5 language is available online. What I want to briefly mention is that there are two areas now: social communication and behavioral patterns. The first area encompasses the old first two areas. When I say social communication now, we're talking about a pattern of functional verbal and nonverbal communication problems. Just like we were before, is now considered all in one area. And when we talked about restricted and repetitive behaviors, that's essentially the old criteria, just like they were, except they have added a new thing, which is for a long time we've known that there are sensory abnormalities in kids with autism. And there's actually evidence that some kids have abnormal pain receptor density in their skin. So there's a solid reason to believe that there are sensory motor kinds of differences in kids with autism. This last area includes things like unusual responses to light, sound, temperature, texture, and those kinds of things. And it includes these non-functional sensory play activities. Kids who play by licking toys or stacking them or banging them repeatedly. A lot of that is stuff that we already knew was happening in autism. It's just been promoted into this behavioral pattern area because in the old criteria it wasn't part of the criteria. So in essence, three become two. The old functional verbal and nonverbal communication become just functional or social communication. And behavioral patterns continues, but there's a slight modification. So I'm going to pass on studies looking at comparison of these. But what I will emphasize is that is an area of controversy. Among the people I respect, many of them say it's not a big deal. And then a few of them say it is a big deal. And the biggest deal seems to be over kids who have the PDD-NOS criteria, who have the symptoms. There's something there, but they don't fully meet the criteria for autism or Asperger's. Those are the kids where there's a big there's possibility of distinction between the new and old definition. And what we have to work out is whether that changes because these kids didn't have autism all along, or because the new criteria aren't good. We'll have to figure that out over time. There is a law of unintended consequences, right? Whenever we make a medical change, it has all kinds of impacts on lots of other things, including the educational system. And that's something we can only find out over time together. I don't know what will happen. Our emphasis is going to continue to be on serving these kids. We're going to continue to learn how best to identify and serve them. And the diagnostic criteria are going to change over time. But we need to make sure that it works. If it leaves kids in the cracks, then it's not working.
I'm just wondering, the sensory motor, is that something that you see in Asperger's, or is that more in the high functioning?
You can see it in Asperger's, yeah, and it's going to be more subtle, but it can be there, it can be things like, there are lots of Asperger kids who do have things like restricted food palates because of tactile issues with food. There are kids who are less pain sensitive, who get themselves in trouble. You tend to see more of it in autism, and you see less of it in Asperger's, but also importantly, you see more of it in autism at a young age, and then it gets better over time. And so if you're looking at Asperger's kids, you want to look at them at a young age as well, where it's going to be more noticeable. It may become very subtle over time. And oftentimes we talk about essentially taking these things and rather than over-diagnosing or pathologizing them, as much as possible later for these kids, we want them to be just stuff you manage.
Right.
You know, like, if you sit at a desk all day, your back can start to hurt, right? You could diagnose that as a sensory motor abnormality. Or you could just say, I need to get up and stretch.
Right.
If you can solve your problem by getting up and stretching, you probably don't need a diagnosis for that. And so we try not to use if the diagnosis becomes a stumbling block for the kid, then that's a problem.
Right.
But yeah, you can see these things in Asperger's.
So what do you do with that? I have a niece that's 16 and she was diagnosed with Asperger's, and now they've changed that. And she's flying between, anxiety disorders and all this, and she's having a real problem with school. I just spent a vacation with her, and I've been in early childhood for a long time and worked with older autism, like when there was only one in a group of individuals way back when.
Now, the important thing to understand is that generally speaking, if you have Asperger's, you have Asperger's. There are some kids who improve so much that they don't meet clinical criteria anymore. That was actually in the news over the last week. But generally speaking, even if the symptoms become subtle, we're going to look and see if there's still the kind of things that were problems before at a more subtle level.
I think she does, but her anxieties seem to go up a lot more as she's gotten older. She's more aware of what other people think of her odd behavior, so now it's getting masked.
Yeah, I'd be glad to talk to you more about that after. I can tell you a little bit about what we would do in our clinic or the kinds of approaches we use. Yeah, but that's definitely something that we work on a lot. And we can make significant progress with people that way. I would like to kind of make sure that we stay on time. We have about 20 minutes left. Really briefly, in a clinical setting, there's no blood test or definitive test that gives you a totally objective answer for diagnosing autism. However, the behavioral tests have been highly validated, meaning that multiple people who have the same training, who use the same instruments, arrive at the same answers. And so they are objective in the sense that they provide consistent answers, even though they're not like a blood test that gives you an A or a B or a B. And it's actually also important to remember that even these supposedly objective biological tests have false positive error rates and things like that. What I want to emphasize here is that there is a pretty well-approved approach that provides consistent answers that are reliable and valid in a clinical setting, even though it involves things like interviews and play observations. Yes?
At what age are you able to see?
That's a good question. Kids who are on the more severe end can be pretty reliably diagnosed after 18 months, and we'll see kids at 18 months. We're working on pushing that back, but really the problem is that the kids who are 3, they don't get put in treatment right now. That's a bigger problem than the fact that they weren't identified at 2. But we can reliably diagnose kids in their 2s and 3s.
And so if they're that age, what do you do with them? Do they go
get to that.
Oh, are you going to? Okay.
Yeah, I'm going to talk about that. We actually went through a process this last year. We don't have a state plan in Michigan for autism. And it's something that we need to develop, and there's a council that was established last year to do that. And I was part of a working group to define how we diagnose autism in clinical settings, and I helped write the working paper for this. And we're currently submitting that to our council to try to embed it in our state plan. It was actually a really good process, and we all pretty much agreed. This was between 8 or 9 large autism practices in Grand Rapids and Kalamazoo and in the Detroit metro area, including the University of Michigan. But you need a thorough diagnostic interview, and the clinician really needs to ask about a wide variety of things, ranging from the gestational and early infancy history to the developmental history after that. unusual development of the body, like unusual development of the face, the fingers, the feet are really common areas that would make us think more about specific genetic issues. Early attachment and temperament, like did this child like being held to comfort them? Language and motor milestones, we have to look at both of those because kids with other kinds of issues do have language delays. Major illnesses of childhood and changes in functioning over time, their socializing, their language abilities now, their motor and behavior functioning, their areas of interest, any self-harm, their education, the interventions that have been done to date. And there are some specific tools. I'm going to spend a little less time talking about these because we've been spending a lot of time talking about diagnosis and I want to get to screening. There's a structured clinical interview, the ADIR. It's used more in research settings, although some schools also use it. We don't actually use it in our clinical setting because it takes up a lot of time and that takes away from our addressing what we do with the kids who don't have autism. And we can get a reasonably reliable answer without it. The ADOS, or Autism Diagnostic Observation Schedule, is basically a set of play and conversation situations that make autism behaviors more evident to the clinician. So you have to understand autism to make any use of the ADOS. It's not going to be effective unless you do. But what it does is it makes these things much more readily apparent. And these presses are designed so that kids who are not on the autism spectrum will behave one way, kids who are on the autism spectrum will behave another way. So those include things like specific situations that are structured so that kids will have social interaction. Like very specific ways of giving a kid a chance to show interest in something I'm talking about rather than something he or she is talking about. Really specific ways to see whether or not they respond to the interest I show in their topics. That's another thing where kids with autism, they may talk very extensively about a topic of personal interest. And even when you try to talk to them about their issue, it's really hard to engage them. So one of the kids I went geocaching with this summer was talking extensively about GPS satellites and how he had a GPS that could access the Russian satellites and the American satellites. And I used to be an engineer and actually know what he's talking about. But I couldn't even engage him in a conversation about that topic of his interest. So looking at seeing whether kids can engage you in their interests as well as whether you can engage them in your interests, looking for things like whether you can get them to play imaginatively, whether you can change the play situation and have them follow your lead. Those kinds of things happen in the ADOS. It's adapted for different age ranges, so it starts at about 18 months, but then it goes all the way up to adulthood. The situations are going to be different. The adult versions for the high-functioning people, more focused on asking questions. They might be questions like, what's the difference between a teacher and your mother, or what's the difference between a friend and a classmate? They might be questions like, you can think of something that made you feel sad, but what's it like to feel sad? Can you describe that feeling of sadness?
What about examples for younger, like preschool age?
For the younger kids, it's going to be things like, if I say, hey, look, will you look where I'm pointing? Can I get you to ask me for things by pointing? Can I get you to play with toys in an imaginative fashion? Do you understand cause and effect? Like, do you understand that if I spin a Jack in the Box, that the thing will pop out, and then when I do it again, will you expect it to happen the next time? Like, if I stop in the middle of that social routine, will you look at me and laugh or say, why did you stop? Or will you just walk away and do something else? Those kinds of things are going to be more in the young kids. And then there are some things that elicit stereotypic behaviors more and different kinds of things. But they're going to be adapted to the kinds of things that 2-, 3-, 4-year-olds do. So they're very play-oriented for the young kids. And the way it works is essentially a lot of different toys. And this is the old ADOS, but the toys are designed so that we give kids multiple opportunities to do each kind of skill. We provide them varying levels of support to see if they'll do it independently, and then with some additional help if they'll do it. So for instance, if a kid doesn't smile when you say something funny, will they smile when you do a funny act, like you chase them around? Or will they smile when you tickle them? And then some of the kids won't smile even for that. So you're looking at different levels of response, like between what a normally functioning, normally developing child would do and a child with severe autism would do. So, caveats to these tools. These tools are really designed for specialists. The ADOS is really like a microscope or a stethoscope. So A stethoscope is not going to allow you to diagnose heart disease unless you already know what heart disease looks like, right? A microscope is not going to allow you to tell the difference between bacteria unless you're a biologist. You need to understand autism to use the ADOS. Doesn't mean you have to be a specific kind of physician or psychologist or whatever, but you do need to understand autism to make sense of the ADOS. And so, for instance, when I do evaluations, I might use an assistant for a lot of things, but I personally do the ADOS hands-on for the most part because I want to see it. That's the whole point. So the more you understand autism, the better a tool like the ADOS is going to work for you, and you'll be more able to differentiate kids who do and don't have autism. There are other components to the evaluation. It's really important to look at things like cognitive functioning. We use those as progress metrics in our clinic, and I'll show you an example of that. We're looking at things like self-care skills. Lots of kids with autism don't find it reinforcing to learn how to toilet, for instance, just like they didn't find it reinforcing to talk. And in our approach, then, fundamental is that when we make this diagnosis, we use it to inform a treatment plan. When I do an evaluation, I make recommendations for medicine or diagnostics. I make recommendations for in-clinic therapies. I make recommendations for school to try to give you guys some help. I make recommendations for the community if a child is ready to do sports or martial arts or tumbling tots or theater class or play dates. I make recommendations for complementary and alternative medicine, supplements, or other things that may help the child, and home remedies essentially. This is an iterative process. So the kids come back on a yearly basis for these full evaluations, come back on a quarterly basis in our clinic for ongoing progress checks. And we're building that to work more and more like what you do, in essence, where kids get a progress card, like a report card. And we really emphasize early intensive behavioral intervention, which is that one-on-one, high-intensity, often 10 to 12 hours, sometimes 20, 30, 40 hours a week of therapy, one-on-one, with a tutor working for a behavior analyst. Let me tell you one story about this. This is a kid in our clinic who was identified by the school at 3 years old. And for the first couple of years, he received only academic interventions, which were great, but they weren't one-on-one. And then for a year, he actually received clinical interventions with us, primarily OT and speech. And after that, he had an IQ of 54. And if you know IQ measures, that's not so good. That puts you in the MR range, the mild MR kind of range. And if your IQ is at 54 when you're an adult, you're going to need lifelong support, although it may be mild. He was in our early intensive behavioral intervention clinic for 16 months, on average probably 8 to 10 hours a week. His IQ a few weeks ago was 84. And so that's within the normal range. At that level, you can understand school. You can participate in normal daily life activities. And in adulthood, if your IQ is at that level, you're likely to live independently and work. So he is in mainstream kindergarten, which is one of the major success stories, the biggest one probably. More fun, he's starting to make friends. He reads bedtime stories to his little sister, which is really cute. We're trying to get him on a t-ball team this summer. These kinds of things are going to be much more successful once kids have a verbal level that we estimated about a 5-year-old's verbal level, because the K through 12 schooling is designed to start there. And so they're going to be able to handle the verbal challenges at school. 5-year-olds, if you think about them also, when you're 5 or 6, you start to have deep and meaningful friendships. Even normally developing kids at 3 or 4 don't really have a fully developed friendship like you would think about older kids having. And so when you reach that 5-year-old verbal level, what we'll see in the clinic is the kids will start to ask, hey, is Billy going to be here today? Or I hope that when the next time I come, Amy is here. They'll start to do things like that. Or they'll start to fight over which therapist works with them. And you don't see that when their verbal level is at a 3-year-old level, but you see that when it's more like a 4 or 5-year-old level. So those kinds of things become more and more possible. And in this particular case, this was a case of a kid where just an early academic intervention wasn't successful for him, but the coordination of the two has been great. We work really closely with his school, and we're really excited that he's in mainstream education. What we think about there is we want to be able to deliver kids who can learn to the K through 12 system, which is the point of early education as well. So our next challenge is to make this happen more consistently and for more kids, because he's just one kid. And we have 10 kids in our early intervention program, and that's because this legislation from last year is just ramping in. We'll probably be in the 20 to 30 range by the end of this year, but that's a small number of the kids just in Grand Rapids that need this kind of help. and there are kids in Holland and Muskegon and New Haven and beyond that use kind of help as well. So let me talk about screening. So screening is a crucial part of the process, and these specific services like applied behavior analysis are going to really make large gains, but only in kids with autism. And so we need to know who those kids are. We can't just apply them to them all. And besides, these interventions cost $10,000, $20,000, $30,000, $40,000 a year. It's not feasible to apply them to every child. So these services work best at young ages, ideally below 6, and the younger the better. An average diagnosis age, though, still hovers around 4.5 or 5. And so if you get diagnosed at 5 and there's a waiting list, you might not get into the clinic until you're 5.5. You're almost 6 already. We do need to push that back. So the autism specialist doesn't see every child. We don't see kids unless there's a problem. And schools and pediatricians in particular, daycare as well, play a crucial role because you all have access to kids long before, early enough that you'd be able to get them into this kind of process, both academically and clinically. So the American Association of Pediatrics has an acronym ALARM. Autism is prevalent, listen to parents, act early, refer to specialists, and monitor over time. That's what the association tells pediatricians to do. And they have a decision matrix that you can get online. And basically, it's really fairly simple. The alarm pieces that are in that top box that you're not going to be able to read are essentially you're looking for kids who have siblings with autism. That's a risk factor. You're looking at kids where the parent are concerned, where another caregiver or an educator or something like that is concerned, or where the pediatrician and him or herself is concerned. If you have one or more of those things, the pediatrician should take a closer look at development. If you have 2 of those things, the pediatrician should still do that, but they should also go immediately to getting the child into early interventions in a clinic, into early interventions in an academic setting, and medical diagnostic services as well. So if you have 2 of those things, like if multiple people are concerned about the child, or one person is concerned about a child whose brother or sister has autism, you should fast track, essentially. And there are some concrete milestones that the Academy of Neurology proposes. So kids who aren't babbling by 12 months, that's a major risk factor. Kids who aren't gesturing, who don't point or wave, like bye-bye or hello or I want that, by 12 months, it's another major risk factor. Kids who don't have single words by 16 months, that's unusual. It may happen for multiple reasons. Kids who don't have spontaneous phrases, we're particularly looking for noun and verb pairings by 24 months. So go home or go outside or wear this or eat pizza. Like those are, you may have more words latched onto that, but you want to look for those flexible phrases. You don't want to just look for I don't want to is technically a phrase, a sentence, but it's not a very good one if that's all you can do. You want to look for flexible sentences using several different verbs and nouns appropriately. Anytime a kid has a loss of language or social skills at any age is also a clear warning sign, not necessarily for autism, but for evaluation, further evaluation. There are some specific tools, but I want to mention, we have a few minutes left, some key concepts. We've already talked about these a little bit. It's a developmental disorder. So first of all, it gets better generally over time, if anything. Although if there are specific stressors, it can temporarily get worse. There is regression in autism. If regression happens in autism where the skills get worse over time, it's typically going to happen between about 12 and 24 months. If it happens at a different time period than that, it's usually for another reason besides autism. And so new problems occurring at 3 or 4 or later are usually for a different reason, but they're still indicative of a clinical evaluation by a specialist. Eye contact and joint attention are particularly important. You're going to look for whether kids will look at you spontaneously, will they look at you to get you to do something. If you, say like with a baby, if you have a rattle and you wave it, will they look at the rattle? When you look at the rattle, will they look at the door when you look at the door? If they want something, will they look at that thing and then look back at you to see if you're looking too? That's joint attention. And integration especially. Modulation and integration, so you're looking for eye contact that's flexible. Like when I'm talking to you, I'm making eye contact with a lot of you, but it's fleeting. I may look in another direction. When I'm talking or thinking, I may not look at you at all. That's normal eye contact, and it occurs in a range. Some of you may make a lot of it, some of you may make a little of it. If I'm just staring at you kind of blankly, whether or not I'm talking to you, that's abnormal eye contact, even though I'm looking at you. So that's not well modulated eye contact. Integration would be like when I talk to you, I don't look at you, or I only look at you and I don't talk to you. So you want to use multiple needs together. And so joint attention is using this for in both directions. For me to get you to pay attention to what I'm paying attention to, and for you to get me to pay attention to what you're paying attention to. And kids should be able to do both of these things starting in those toddler years. And in a simple level in infancy. So again, we talked a lot about this. The communication should be functional, meaning you should be seeing communication that's for a purpose, for asking for things, for telling you about things. If you think about that, language is naturally reinforcing. Babies who learn to talk can tell you they're thirsty, and so you're giving them a drink instead of changing them. They can tell you they're hungry, so you're giving them food instead of a nap, right? And so they get what they want. That's naturally reinforcing. That's what falls off track with autism. And so if you're not seeing language used to obtain ends for functional purposes, that's a clear indicator that you should be thinking about autism. A couple more things, and sorry we're running a little late here. I want to mention briefly, I'm going to skip over some differentials between different kinds of delays. Do want to mention these things, however. From 16 to 30 months, there's a great tool called the Modified Checklist for autism in toddlers. It's available for free online at this website. It takes a couple minutes to fill out. It's 23 questions. And there are some questions that are of low risk and some questions that are high risk, and so there's some key items. Parents can fill this out 2 or 3 minutes. It's well understood by most clinicians. And this will tell you if a child needs further evaluation by a specialist. So it's available online. You can actually fill it out by clicking the boxes and get a score right away. So people at the University of North Carolina are actually developing a tool that is useful before 18 months. It's not being used clinically yet. There are some tools for older kids, the GADS and the GARS, the Gilliam Autism Rating Scale and Aspergers Disorder Scale. Those start at 3, so those are good options. There's the social communication questionnaire that starts at 4. So there are a number of options to screen older kids. And a lot of these, I think, are already in use in the educational system. And so your IEP team may well be using something like the GARS or GADS. If possible, as in the AAP model, what you should do is use these simple early screening tools first, and then if you're seeing problems, simultaneously refer. Get the kid into their pediatrician so that they can see if they need to go to a specialist, and then also start the IEP process. You want to make false positive errors. It's okay if some of these kids turn out not to have autism, because there are multiple layers in the system that will identify that and get them into the right kind of services. At the screening level, you would rather do that than have the kid go without help. And so that's an important consideration. And so just briefly, what to do next. The big thing for clinical services is start with a pediatrician, and they need to be closely involved in this process. They'll determine if the specialty evaluation by someone like me is appropriate. If they don't have a pediatrician, they need one. And then depending on the pediatrician, they may send you to a specialist. Depending on the insurance plan, there may be some wrinkles to how that works. Particularly for Blue Cross and Priority Health insurance plans. They have centers of excellence, and so some places are one and not the other. For instance, Spectrum's a Blue Cross center, but not a Priority Health center. We're a Priority Health center, but not a Blue Cross center. We'll work on all that with you. We have a practice manager, and most of these other clinics do, specifically to help figure out how to deal with all that. Most of us have limited scholarship programs for kids who don't have access to care. In fact, the kid in the example was being seen through a scholarship. And the rules for Medicaid are still being finalized, and so that's 30 or 40% of kids. We're still figuring out how that works. It's supposed to happen starting around April. So there's some information about how to get a hold of us. We do videotape a lot of things, and so we put them up, especially at the CFA Rounds website. And so there's lots of educational resources available to you there. As part of the community, we're really deeply motivated to work with all of you to help achieve the best outcomes for these kids. So sorry that went a little long. As I pack up, I'm happy to answer questions. Make sure that you get one of these.